Okay, so let me welcome all of you to the first of four seminars that will deal with the World Development Report. That will deal with the economization of health. I will be introducing the speakers. Jean-Paul Godelier will be handling the question period after the talks. We would like to ask you to send in to type in your questions on chat. With a lot of experience, we've learned that questions seem to be a lot shorter and a lot more targeted when they're written down than when they're oral. I should also let everybody know that this session is being recorded. Both speakers have agreed to recording the session, so this is going to be part of the historical record. Let me also mention that the second session has already been set. It'll be about the World Bank and its role in global health with Jean-Paul and Marley Tishner. Papers will be pre-circulated. We haven't really decided on the mechanism of that, but what will probably happen is we will send you a request to register for the meeting, and anyone who registers for the meeting will receive the texts of the papers. Okay, so on that note, let me get out of the share and introduce the speakers. Our first speaker is a very familiar name to anybody who has worked in the history of global health. Dean Jameson is Edward A. Clarkson Professor Emeritus at the Institute for Global Health Science at the University of California, San Francisco. He has taught at Harvard and UCLA and was an economist on the staff of the World Bank, where he was the lead author of the work that we're going to be discussing today, the World Development Report. He's been leading or co-author of many key global health publications, most notably Disease Control Priorities in Developing Countries, which was first published in 1993, a second edition in 2006, and a multi-volume third edition published between 2015 and I think 2017 was the last one as far as I know. I should also point out that he was the lead author of the report of the Ad Hoc Committee on Health Research in 1996, which was a major influence in the reconfiguration of global health research institutions around the turn of the century. He recently served as co-chair and study director of the Lancet Commission on Investing in Health. Okay, so what I will do now is ask Dean to start, and I will try to handle his.
That is what we're talking about today. I had a large panel on my wall for many years that had this cover in 9 languages. It was too big to lug around, so unfortunately I don't have it anymore. I wish I did. So this was available in 9 languages. So let me just speak without slides for the next 15, 20 minutes. So take that off, George, please. So I'm taking it this series of talks on economization in health. We'll have at least one more discussion next time on World Bank issues in health and relations to WHO. And so I'll begin part of that discussion, maybe even introduce it now. But many, many years ago, when Robert McNamara was president of the World Bank, he had very strong feelings about the importance of population control, and there was a population department created within the bank to provide financial support projects to countries in the population area. And they had a steady record of projects, which was 2 this year and 4 next year. That went on for about 10 years. They never quite got to the 4, and the department became a little bit of a black sheep in the bank. Senior management of the bank in the early 80s probably decided to broaden the mandate to include health and nutrition, and brought in a new director, John Evans, tasked with doing that. So long before the WDR 1993, the bank had decided that a lending program and a IDA credit program in health was worth doing. And it was solidly established in the bank, but not a large program in terms of money as the bank was at that time. The bank's research group is led by a chief economist, vice president chief economist, who also serves as the economic advisor to the president of the bank. And one of the annual responsibilities of the chief economist is to suggest topics for each year's World Development Report, and then to supervise the process of getting it written more or less on time. And at the World Bank at the time, by the time I'm talking about late 80s or early 90s, was a full-fledged participant, I'd say, in the Washington Consensus. By Washington, people mean different things by that, but it's typically a limited government approach to development, an approach that favors relatively free trade and capital movement and care with the size of government budgets. We're not seeing that, haven't seen much of that for a long time, but it was pretty much the dominant view among many economists, academics, and officials in institutions like reserve banks around the world, treasury ministries around the world, the IMF and the World Bank. And there were a couple of World Development Reports, I think in 1989 and 90, or 90 and 91, that were quite influential, I think, looking back at them. And I thought at the time, still think, that they were quite good reports. One was on how to deal with poverty in the context of the Washington Consensus. And the second was a broader look at the Washington Consensus and how its policies would lead to more rapid and more inclusive growth. So those two documents, I think, represent a strong statement of the role of very limited government in the development process and how you can achieve development goals, they argued, would best achieve development goals with limited government. Larry Summers then became the chief economist in 1991. He was an academic economist, quite successful academic economist, known at the time and known later for his abrasiveness and occasionally unpopular views on various topics, and I'll turn to one of those in just a moment. Summers was a Democrat, served as Secretary of the US Treasury under Clinton, and chief economic advisor to Barack Obama for his first 2 years. So he's a prominent Democrat, but a very conservative Democrat, which has actually cost him positions from time to time because of opposition from the left side of the party. So he's on the right side of the party and very much, I'd say, a believer in market approaches to most everything. So I ended up working closely with him at Abdo for the better part of a year. And my take on him was one that I think is reflected in the, if you wish, ideological direction that the WDR 93 took. His view, I would argue, of the value of markets was a coldly instrumental and practical view. He didn't care, as far as I could see, anything at all about markets per se. He thought, for many, not all purposes of development, markets work best. And that sounds, of course, very sensible, but I don't know how many of you are economists, but I can assure you there's quite a lot of economists who take a very different view, that a very decentralized, pro-market, consumer sovereignty view is good in and of itself. Now, they wouldn't tell you that, but that is clearly, as far as I can see, the way they behave. And that becomes hard to argue with, and a strong element of where we were. What Larry decided to do in the aftermath of these two very market-oriented WDRs was put in place a series of 3 WDRs that looked at areas where the role of the state was and should be clearly highly central. And so the sequence of 3 began with a WDR on the environment. Second was WDR 93 on health. And the third of the series, WDR 94, was on physical infrastructure. And so his intent was to balance the pro-market perspective that had been emerging from the bank, or at least that's how I would read his intent. Summers, I learned when I was interviewing for the job of director of the WDR, is a technocrat in the sense that he's highly interested in specific things like epidemiology and diseases and disease control measures. And not all economists are. I had my job interview. I was living on the West Coast at the time. He'd scheduled me for an hour at his house in Northwest Washington on a Saturday morning. So I showed up and we ended up speaking for 3 hours about many different things. But it was typical of him, once he gets engaged in a technical point, he doesn't want to leave it for quite a while. He concluded that meeting with my homework assignment for the next day. And what he said was, Dean, I assume you already have 3 conclusions in your mind about what this report would say if I asked you to be director. I'll let you think about that. I'll let you think about that for a day and tell me tomorrow, write to me tomorrow about what your 3 main conclusions were. So I'll turn back to that in just a moment, but that led us into health policy, at least as it's discussed in the United States. It's a settled issue in most other places, but that's about universal health coverage. And universal health coverage was in no sense a dominant or even barely an acceptable view in the World Bank in the early 1990s. It was cost recovery, then mechanisms for dealing with the poor, subsidies for the poor, or other things like that. Universal health coverage has the characteristic, to put it in a slightly pejorative way, of having this coercive power of the state be used to deny individual citizens the right to be uninsured. Now that puts it in a negative way, but that's what the word universal means. And that concept, even more softly put, was anathema to a large number of economists in the World Bank and much more broadly, even though by then, obviously, completely accepted concept in most high-income countries. So we dealt with that for many months, and Summers' initial position, initial predilection was to find that coercive role of the state undesirable. But I'd say within a few months, that was behind us, and he was fully aboard. So there are questions of basic packages and health benefits packages that are very much on the agenda today. So those issues were settled. There was one other major thing that led George to the WHO report on health R&D priorities later in the decade. So I had these three messages, which more or less carried through. And Summers, most of the way through the effort, took a position in the Clinton administration, the new Clinton administration's Treasury Department. And we had an acting vice president for a while, then a new vice president. And the new vice president was a complete macroeconomist who had some interest in health, but no serious interest in economics of health or agriculture education, but a smart and interesting guy. Anyway, he essentially repeated what Summers had asked me to start with. He says, Dean, I assume that you probably had your main thoughts about how this report would unfold early in the process. So don't bother to summarize those for me. What I want to know is what conclusion did you come to that you did not go in to your year's work holding? And that certainly was an unexpected and I thought interesting question, but it had a very, very easy answer. And the answer was around the absolutely essential role of advances in science and technology, in medicines, diagnostics, vaccines, epidemiological knowledge, that all of those factors were basically what drove the huge transformation of human health that had been taking place in the 20th century, but particularly in the second half of the 20th century. It wasn't better markets, it wasn't higher income even, it was only a little bit better education levels in the population. It was adoption of the fruits of technology. So anyway, that was one thing that I came away with and something I still believe quite strongly, but that I hadn't started with. And working with WHO on that led to further analyses since that conclusion was late in the World Development Report process. Didn't figure too prominently. It figured, but not prominently in what we wrote. So in collaboration with WHO, we returned much more substantially to those questions later. So it's a long set of issues that are very interesting to me, but I think not directly relevant to where we are with the World Development Report. So by the time we were then well into writing it, the basic question that Summers had come around on, the basic agreement that a main message of the report would be universal coverage, perhaps the package of interventions to be universally publicly financed would be limited. Certainly the question of what should be in that package was then and remains subject of much discussion. But on the topic of what should be in the package, we had been working well before Summers joined the World Bank on what became known as the Disease Control Priorities Project. Again, I spent a lot of my life in the bureaucracy as a bureaucrat. Remember, my sister's an academic at Johns Hopkins, and she's quite a pure academic. And The Economist had written, after the World Development Report was published, words to the effect that it was a good report, and even bureaucrats could make a difference, was what The Economist said. So I was pleased. I thought that was nice coming from The Economist. My sister was quite outraged. But the question of what to include in the package, to me, not quite a bureaucratic question, but very much a technocratic question. How, for a given amount of money, for $1 million, what's the most you can get in terms of whatever your objectives are, but basically objectives of either reducing mortality or improving health more generally? How much can you get for $1 million? And that question had been on my mind for a long time and had led to the first disease control priorities project, because of the tension between interventions to address cancer and heart disease, stroke, chronic lung disease, the non-communicable diseases, psychiatric disorders, and those that addressed infectious disease, particularly infectious disease of childhood, but also at the time, the emergence of AIDS on the world scene. And I had begun my work on health working in China, where the NCD agenda in 1990 was already a prominent part of the work. And so one of my objectives in this exercise of looking at priorities was to really assess where, given the extremely powerful and inexpensive interventions that exist for dealing with many infections, certainly most of the infections of childhood, under what circumstances and why, what interventions against NCDs make a difference. So this project on disease control priorities reflected an attempt to answer that question in a systematic way, and to answer that question of in the context of very focused attention among my bosses. I was the head of the bank's health policy group at the time. I was instructed to spend all my time on AIDS, and I personally thought that was just really wrong. So this disease control priorities was, in a way, a bureaucratic response to my bosses to kind of deflect them from pushing me quite so hard on spending all my resources on AIDS. So we had a lot of work done by 1992, pretty well ready to publish it. And the World Development Report of 93 was able to take advantage of the homework that had been done, if you wish, on priorities that reflected mostly cost effectiveness, but also to a lesser extent, probably too little extent, the financial protection of populations from expenditures associated with illness, and the broader questions of how to deal with the concerns, political concerns of trying to provide everything for everybody, as opposed to a more constrained set of things that could actually be financed. So we tried then to develop a package that was reflected both the needs of countries and the priorities of dollar value, of mortality value per dollar spent. And that led to work on the burden of disease. So the World Development Report 1993 developed the first set of estimates of the global burden of disease in collaboration with WHO. And WHO did collaborate closely with WDR 93 there was an Assistant Director General, Jean-Paul Jardel, who was assigned to work with us, and he provided a great deal of WHO resources in support of WDR 93. But one major input that they provided was a lot of technical information on assessing the burden of disease. And the technical issue there was a technical and political issue. If you looked at the WHO numbers on deaths by cause of major infectious diseases in developing countries, or all diseases in developing countries, they would tend to have a list of 10 or so things, but they wouldn't have a total at the bottom of the list. And the lack of a total reflected a great deal of internal dissension among the disease programs about whose program was most important. And if my disease, malaria, killed 2.5 million people a year, and your disease, acute respiratory infections, only killed 1.2, then you're not as deserving of bureaucratic budget. I mean, you can see how that goes, and it's perfectly human and perfectly natural. So if you actually went around to the programs in WHO and wrote down, let's say, the causes of under 5 deaths by program, as reported to you by program, literally you would get a number when you added all those totals up that was about twice the total number of under 5 deaths as calculated by the demographers. So that they weren't fitting into the envelope. So a major objective and a major contribution of WHO to our work on WDR 93 was to try to get an assessment of the burden of disease that lived within the total death envelopes that the demographers provided us. And then in addition to that, so Alan Lopez was the WHO official at the time who had been thinking about those questions for a long time and worked closely with us then to come up with these estimates of deaths by cause, by region, that were completely consistent with each other in terms of demographic totals. Chris Murray, we asked to add on disability information so that it was a burden of disease being assessed, not just a burden of mortality being assessed. Actually, George, if you could put up the next slide briefly, which is the first report of the global burden of disease. One of the things that WHO did, so this is a paper in the bulletin of WHO, and at the end of their collaboration with WDR 93, I'm making it sound very good, and it was mostly very good, but of course there were tensions from time to time. But Dr. Jardel devoted a special issue of the Bulletin of the World Health Organization to background papers prepared for WDR 93. And so this paper was one that reported on the global burden of disease estimated in 1990. I actually revisited some of our numbers much later in Commission on Investing in Health to see what in the year 2012 or 2013, if you re-estimated in light of all of what you knew in 2012, if you re-estimated the burden of disease in 1990, how close would you come to what we actually estimated in the WDR and then in a slightly more extensive form in this long paper. And we actually didn't do too badly. There were 1 or 2, I think maternal deaths was way off, but mostly we were fairly, looking back on it, got it, right is not the word, but whatever came later ended up being fairly consistent with what we did then. I think it was more or less right. So there, was that and 7 or 8 or 9 other background papers that WHO published in the bulletin. So that's enough for that slide, George. Take it down. We looked at the burden of disease, we looked at cost effectiveness, we tried to put this together in a larger picture that reflected this universalism concept, even if it was around ultimately, in one sense, a fairly limited set of interventions, 2 sets of interventions that we looked at, one for low-income countries, one for lower middle-income countries, more expansive set. But even though it didn't cover all that much in some sense, it still was expensive. Probably Abdo has a much better sense of this than I do, but when people later at the World Bank, WHO, tried to help countries implement a package like that if they were interested, the dollar values were pretty high. So we then published this report, and let me just finish with my thoughts on how we got into it and first sense of reaction. But what I thought the report had done in a broad sense was 2 things. One, it was a distinctly technocratic report. It talked about diseases, it talked about immunization programs, it talked about drugs, it talked about specific epidemiological issues. It talked about what we would today call non-pharmacological interventions against AIDS. We talked about that at some length because we didn't have the drugs at that time for AIDS. So it was very much more technocratic than the World Bank is at all inclined to generally deals more with issues like decentralization, management, implementation, training, kind of the systemic issues, which are obviously very important, relative to the technical issues around what the systems should do. So that was one distinctive feature of WDR 93 as I saw it, that put it intellectually in a way much closer to Geneva, much closer to WHO than to many of my colleagues in the bank. And the second was to return to this central question of health policy. Do you impose finance of universal health coverage on population? And we were clear about that was positive. That was still not a story that the bank was uniformly willing to buy into. But what I felt was that we had produced a center-left report in a center-right institution. And Abdo will perhaps have very different views than mine, but that center-left character of the report, I had hoped would make it acceptable outside the bank, and it was in some places, and certainly was not, as perhaps some of you know, in other places. And the same within the bank. There was acceptance in some circles, rejection in other circles, and that was, I would say, it was not a neutral response. There tended to be people inside the bank and outside the bank who quite liked the report, and there were quite a few people who didn't like it at all. And those communities, to me, ended up, interestingly, the pretty far right community and pretty far left communities were the communities that really didn't like the report as I read it, as I read the politics I read afterward. So that perhaps is too long an introduction to how we got to 93. And Abdo, you might have further reflections on the process of and content, messages of the report, as well as beginning to reflect on what happened afterward.
Okay. We're going to come back to Dean in a moment, but first let me introduce Abdo Yazbeck, who is a leading health and labor economist who spent 22 years at the World Bank, where he managed various regional health programs. He's an associate editor of the Journal of Health Systems and Reform, and is on the faculty of Johns Hopkins University Bloomberg School of Public Health. He has authored 7 books and edited 5 journal issues, and is currently working as an independent consultant. Abdo?
Thank you very much. I was so worried about joining a panel with Dean Jameson. It's almost impossible to follow Dean, so that's a hard one. I apologize for that. But I will offer something, I think, complementary. Dean can give you the real story from a 30,000-foot elevation that gives you the big picture. What I can do is much more on the ground, specifically in terms of the follow-up. How did the WDR 93 get used operationally, and what are the potential legacies to that? Let me see how I can change the slides. Here we go. So I have a couple of slides, only 10 slides. A little bit about my take on why the World Bank did a report on health in 1993, slightly different than Dean's. 3 of my favorite charts, graphs. I call this memory lane, just to give you a sense on some of the things I worked on. A little bit about the operational legacy. Actually, that's the part you're interested in. With a focus on one specific example, I spent 7 years working on Bangladesh, including 2 intense years on a project that applied WDR. It gives you a sense of what happened in many countries. And I'll close with a couple of slides on potential legacies in terms of what happened after WDR. So Dean gave a fantastic story as to why the chief economist at the time, in a way, in an ideological way, wanted a WDR on health. And that was wonderful for me to learn. I did not know this. A few years ago, I started a project on my own called Health and the Economy. And part of it was to actually understand health as it went through from the 60s to 2015 at that point, in terms of where it plays, how it plays. And I looked at the World Bank data, because all World Bank data, all World Bank publications are available to everybody. We call it the sunshine rule. No bank document or database is ever meant to be kept from others. So it's fantastic. Anybody can get access to it. So the 2 charts you have in front of you are charts that on the left is health projects, that is projects that the World Bank identified and funded for health. And on the right, which is the more important one, the amount of money in millions that went from the bank to focus on health. Notice where the World Development Report 93 was initiated, in that green bar. It was initiated at a time where health was starting to show up as a reasonably substantial part of the bank portfolio. And in many ways, bank staff, bank operations needed to know what the hell to do with health. Because the history of the World Bank, who people may not know, the World Bank was started as a post-World War II institution. It was called IBRD, International Bank Reconstruction and Development, and it was developed to rebuild Europe and parts of Asia after World War II. Once that job is done, it recreated itself as a premier development agency, but it kept the reconstruction part, the construction part of that. So it was focused only on physical infrastructure, and that is building things, building roads, building dams. Subway in Tokyo was after the World War II, but then other major investment physical projects. And something was happening in the 60s in the sense that development thinkers were thinking, maybe economic development or developmental is not just about physical, maybe there's a human dimension. And that's where the social sector started. And Dean mentioned population was our entryway drug. for the World Bank. Education and population were the two first sectors. And Dean will remember the unit he used to be in charge of was used to be called PHN, Population, Health and Nutrition. So it started as population, and eventually it moved into population, health and nutrition. And as you can see from the chart, health was starting to become an issue. And therefore, having a World Development Report on health gave bank staff a little bit more of the what does the science, what does the research tell us, and what can we do? And I'll turn to that when I get to my slides in terms of the operation. So these are two of my three favorite slides from the World Development Report. These two were initiated by a certain Dean Jameson, who came to me and said, Abdo, I'd like you to repeat, the first one to the left is a version of what's called the Preston curve. The Preston curve is a fantastic correlation which links on the vertical a measure of health outcomes, in this case, life expectancy, on the horizontal, the level of economic development of a country, per capita income. And what the Preston curve shows is a correlation. And please keep the word correlation in mind, because it has been misinterpreted by economists for a long time. So a correlation means things are happening at the same time, but it has been interpreted as the economy grows, health improves. In fact, I have shown in a paper I wrote recently that the relationship is actually health outcomes produce improved economy, not the other way around. But that's not the topic of this presentation. At that time, the relationship was strong. And Dean asked me, can I repeat the Preston curve, updated, but can I do it over a 30-year period of increments? So I was able to get data from 1900s, 1930, 1960, 1999, 1990. And Dean, maybe we want to do 2020. What do you think? To look at what happens to the Preston curve every 30 years. And I loved what came out of this because it maintained the shape. It told us there is a correlation. There's quite a bit of variability around this correlation, but it showed this fantastic shift. Now, I believe Dean interpreted this in the text to say, this is the result of improved technology. This is the result of new findings in public health, in medicine, that allowed us at the same levels of development to have improved health outcomes. The chart to the right is one of my favorite and one that took a lot of energy to get it done. Dean was very interested to go beyond the Preston curve. He said, can we go further? Can we control for a couple of things? Per capita income, but maybe for education stock. And Dean shared with me a database the World Bank had produced, the education group, that actually had education stock, not levels, but stock. And so using that, working with a demographer and the team, fantastic guy named Ken Hill, we were able to control for these two variables and say, okay. And so what you see on the chart on the left-hand side, on the vertical, is what is the current health outcome, in this case, life expectancy, different from what you would expect it to be given the per capita income of the country and given the education stock. So anything above the zero line means a country is overachieving relative to level of income and educational stock. And I love this chart. Then Dean made it a little bit more complicated, said, can you do the same, but for per capita spending on health? Now, we all expected a linear, or at least a relationship that went from worst outcome, lower expenditure, to better outcome, higher expenditure. And what we got was this crazy scatter graph, which unfortunately, again, was misinterpreted by economists at the bank and elsewhere. I see it as an important message that says, more important than spending money, it's how you spend the money. Unfortunately, right-oriented health economists, not the health economists, economists saw it as saw it as proof that actually spending doesn't matter, which is not true. This is overall spending. Anyway, those are two fun charts, memory lane for me. This one is the big one, and this is the one. It's sort of a wonderful chart because it reminds me of two people we lost. And so this was the brainchild of our colleague Phil Musgrove, who passed away some years ago on a boat in Iguazu Falls, but also reflects a conversation Phil, myself, and Jose Luis Bobadilla had a few days before we produced this chart. Jose Luis was a fantastic physician, health specialist, who also passed away, unfortunately, in an airplane crash, also in Latin America. And what Jose Luis was saying is he was so worried that people will misinterpret this data. And what is this data? This is what Dean was talking about, the results of the work he was doing with his colleagues on the disease control, which started to capture the return to different spending. So what is it, the cost-effective outcome of investment of $1 or $10 in terms of disability-adjusted life year? And so this was an attempt at measuring the return to a certain investment. And the reason this was important to us, and the reason why Phil Musgrove was very concerned that this would be misinterpreted, and unfortunately it was misinterpreted, is I underlined 2 words on each scale, which is the log scale. Unfortunately, to be able to fit this into a graph, we needed to do a log scale. And Phil was very concerned that people will not understand what that meant. So we added the stuff on the right. This is $1 for DALY. So this is buying a disability-adjusted life year by spending $1 versus $10 per DALY versus $100 for DALY versus $1,000 for DALY versus $10,000. So each line represents an order of magnitude difference. And the point here is that if you're going to be spending money on health, shouldn't we be focusing on getting the most return to outcome? And I'll come back to that in a minute, but let me keep going. So this was the point of this chart, was to tell us there are some things that are obviously highly cost effective. There's certain things that are obviously highly cost ineffective. But our concern was, this is not accurate data. We were worried, Jose Luis was worried, that Harvard University will be running around with a black box with data and says, okay, so how much should the country spend? This is how much money you have. These are the 20 interventions you should spend. Unfortunately, he was correct. And Harvard University did that for a number of years. And this continued, unfortunately. So what are the operational legacies? I'm going to talk about the 2 sort of big pieces that, in my view, were extremely important and heavily impacted the World Bank and other agencies afterwards. One was a measurement issue. And the idea was, as Dean mentioned, up to this point, our focus had been on mortality. And there was a need to define the enemy. And in this case, the enemy was burden of disease. And importantly, it was important to understand what can we do about that enemy. So the cost effectiveness data allowed us to say, okay, this may be a big enemy, but we don't have interventions that are cost effective. And so it allowed us to think more about defining the enemy and defining what we can do about it. Bringing that kind of a measurement made a big, big difference. The second line is really the big, big legacy. The World Bank after that, and many other agencies after that, focused on the idea of a package of services, making budget choices much more explicit, in my view, much more ethical. Because before this became the operational instrument, we honestly did not have a way of helping countries think through choices and implication of choices in terms of budgets. And this is a huge legacy I'm happy to talk about later if you want. 2 additional legacies. It was a consolidation of a shift away from infrastructure. I mentioned in a minute ago that the bank was a reconstruction bank, so it was mostly physical infrastructure. And so the first instinct in education was to build schools. The first instinct in health is to build hospitals. I call these things white elephants. If you want, in the Q&A, I can tell you where the expression white elephant came from. Fantastic explanation that, like all good stories, come from India. But what the WDR allowed us to do was think of investments in health and projects in health. I'm going to show you an example in a second that doesn't look about building things, but looks about spending, looks at decisions within a health system to make a difference in people's lives. And the second part of that is something I've lived for 28 years. I spent most of my time in development as the go-between between the Ministry of Finance or Treasury and the Ministry of Health. And it's mostly over budget discussions. And what WDR 93 and the approach relating to cost effectiveness gave us is a joint language between Treasury and Health. See, Treasury thinks in terms of investments and return to investments. Health doesn't think that way. And this was an attempt to bring that language together. And finally, and Dean may want to talk about this, an interesting legacy of WDR 93 is that it led to the Gates Foundation focus on health. When Dean is not sharing stage with me, I take full credit for this. And I say it's because of my work on WDR 93 that the Gates Foundation decided on health. But Dean has a better story than I, and actually a truthful story in terms of that. Let me turn next to a specific example just to ground it into the reality. So I left the bank after WDR 93 to work as an independent consultant or as a consultant for a USAID project. And after that, I was recruited back to the World Bank in 96, specifically to apply WDR 93 to a huge project in Bangladesh. Bangladesh at that point had 20 years of support from the World Bank on population and health, and they wanted to apply WDR 93. So this led to a project, the fifth project, which was 14 donors and lenders, a 5-year project with the government spending came up to $2.9 billion. Don't get too excited. $2.9 billion for 5 years for a population of 130 million comes out to $3.5 per capita per year. And this was what Dean mentioned earlier. The cheapest package we costed in WDR 93, Peter Cowley and colleagues, was $12 per capita. And here's Bangladesh with all the donor money coming in, and the best we could do was $3.5 per capita. And this was the fun part of the operational. How do we cut a $12 package to 3.5? And I documented this in a paper called An Idiot's Guide to Prioritization in the Health Sector, with the idiot being the author. And because at that point, I was trying to find out what else is there, what other examples are there for how you prioritize. And shockingly, other than WDR 93, there were very few published papers that actually gave us a roadmap for how you go about prioritization. I underlined for you some of the elements of this. The focus was on the unfortunately named Essential Services Package. I tried to convince the Secretary of Health that ESP has a different meaning, but that was decided to go. Basically, it's a package, and it was a package of services that were cost effective. And there was an agreement that the majority of the public spending will be spent on that package, and that at least half of the donor money will go to it. You may want to wonder why less donor money goes to the package. I can tell you answers to that in the session if you have specific questions. Finally, two quick sort of slides in terms of what's happening. So there's been a lot of work on packages, fantastic work by Amanda Glassman and her team at the Center for Global Development. And Dean may know that the person who started the Center for Global Development here at DC used to be his boss and my boss as well. It's a think tank. And what they're doing there, which is brilliant, is they have been documenting what countries are doing on these packages and identifying what's still unresolved about it. So, I'm not going to go through the 10 pieces here, but you can see from what I wrote on the slide, it's more than economics. Ethics, evidence, population comes into it. Then you have to somehow operationalize it in some criteria: health, financial protection, equity. And by the way, Dean has been working on that. So the health, financial protection, and equity is a new cost effectiveness tool that Dean has been working on, which combines all these three. I think it's called extended cost effectiveness analysis. And then how do you shape it? Do you identify that as a set of services, as disease focused, as levels of care? How do you bring in and out interventions? What are the rules of doing it? So there's a lot of fantastic operational work still ongoing all the way around the world from this legacy. The last piece here is an interesting work by another colleague of mine, Maria Luisa Escobar, who's Colombian, who had left the bank to work with the government of Colombia in 1992-93, which led to this incredible reform with the then Minister Londoño, who we've also lost since then. And then she returned to the bank and was leading the World Bank Institute, the unit I used to lead. And she did something brilliant because of the experience in Latin America. They realized that there's an interesting intersection between the economics of a benefits package and the legal dimensions of a benefits package. Because in Latin America, the legal system was being used to do good and bad things to this benefits package. So if you think in terms of this 2x2 chart, anything above the line is that these are services that are prioritized. And you can use the legal system, like in the red box, to ensure that something that's prioritized is actually made available. So that gave the legal system a specific set of issues to say, we have agreed as a government to provide the services, and you can go and sue the government if they didn't provide that for you. And that's an enforcement mechanism that we didn't think about it in at least I didn't think about it in 1993. That's powerful. But there's a second part in the Roman 3, which is a very negative experience where actually there's litigation to blow away the benefits package. And there are examples from Costa Rica, from Brazil, and elsewhere where this incredible situation where you have services that are highly cost ineffective, in which government was sued and the legal system gave the right to this cost ineffective service. What does that do? It means fewer money, less money is available for cost effective service. It's it produces terrible outcomes, but it's an intersection between the legal system and the economization, for the lack of a better term. I will stop here. I had a bonus slide, but I think you guys have more fun things to talk about than this. So I'll stop here.
Thank you.
Dean, we're running a little bit late, and I see that there are huge numbers of questions, but if you could sort of maybe speed up a little bit your final session so we can get to the questions, I think that would be really useful.
Sure. A few just reflections on some of the things on the academic and policy side that followed the WDR and work that continues. One, as I mentioned already, was this WHO-initiated look at R&D priorities and how important they were. In the late 90s, it turned out that three or four of the foundations that had been substantially supporting health research for developing countries had all decided that they had stimulated a lot of good work, that they viewed their roles as catalytic, and the catalysis had happened and they were all going to get out. So all these four catalytic organizations decided more or less at the same time that they would be getting out of it because the job had been done. Of course, somebody has to carry on after the catalytic work is done. And so WHO was very concerned about this, and we worked with them on this approach to both prioritizing product development decisions, basic research decisions, as best you can, which is certainly not easy, and even more assembling the empirical arguments for the importance of continuing that work. Larry Summers, who's played an important role in my intellectual life, had gone on to deal for many, many years with other things in health. I mean, he was in the US Treasury under Clinton, became president of Harvard, quite controversial president of Harvard, moved back into the Obama administration, returned to being a professor at Harvard shortly partway into the Obama administration. Essentially, he had 2 years leave and he had from Harvard and he had to go back or resign. And about that time, Summers became very re-engaged in the topic of global health. He'd always been interested. So one thing that he had done as president of Harvard is put a fair amount of institutional resources at Harvard into global health, and those some of them remain visible today. I asked him, after a conversation with the editor of The Lancet, Richard Horton, I asked Larry if we might do a retrospective on what had happened as a result, as far as we could tell, of the publication of WDR 93, and what we would say today was 2012, in terms of messages that were similar or different. So Richard Horton, as perhaps you know, has been extremely successful long-term editor of The Lancet. He's distinctly to the left politically, and Summers not only was considered a bit right-wing, he had some positions, positions were ascribed to him that made many people on the left uncomfortable, to some extent reasonably, though I think not entirely. Anyway, Horton wanted a 25th anniversary look at WDR 93, and a 20th anniversary look at WDR 93. And that's what he'd asked me about taking on, creating one of these Lancet commissions. I said that I would do that, but given the intellectual role that Summers had played in WDR 93, I really wanted at least to explore whether Summers would re-engage with us and spend a serious block of time. Horton was concerned because of Summers' reputation as a conservative, and I arranged for us to have lunch together in New York. And Summers is a very abrasive guy a lot of time. He can also be quite charming when he decides he wants to do that. So he was on his best behavior at that lunch, and Richard Horton became very enthusiastic about this commission on investing in health that Summers and I then co-chaired. So we revisited a lot of the issues, and I think probably some of those issues will come up in the questions. But the Lancet then published 2 long reports from the Commission on Investing in Health, and those have had, whatever influence they have had. So that, plus a continued series of analyses in the disease control priorities line of work, has occupied a lot of my time professionally over many years. Let's just look quickly at the last 2 slides and then turn to the discussion. The flavor of all this work just remained highly technocratic. This particular slide, it concerns ischemic heart disease and mortality from ischemic heart disease in the world and by region. You see on the left, China, Eurasia and the Mediterranean, India, Latin America, Sub-Saharan Africa, high-income countries. The question that we were addressing was, to what extent were there ongoing improvements, that is reductions in mortality from ischemic heart disease, which was already becoming dominant or at least extremely important in much of the low and middle income world. And I had gone into this thinking that, perhaps slowly, but everything was getting better, that mortality rates were being reduced, and that despite that, the changing demography, the simple growth of populations, and the changed age distribution of populations toward older ages were creating headwinds that caused the absolute numbers of deaths from ischemic heart disease to be increasing. So it'd be a rate of increase. When we then controlled for age distribution and population size and looked at the rate of reduction up to, I think, about 2015, I can't see the number myself, 2016. The final column was very different than I had expected. What that shows is the annual rate of change, percent per year, in death from ischemic heart disease controlling for all of the demography. And so a minus sign reflects a negative growth rate improvement. The striking thing in that column, to me, and one of the, I think, defines a lot of the challenge for health systems around the world, what is that in the two most populous countries of the world, China and India, the age-adjusted mortality rates from IHD were increasing, and quite rapidly in China, reasonably rapidly in India. So China has rightly, I think, been viewed as having had extraordinary success in healthcare. But this points to a set of problems that they really haven't been, I think, still aren't addressing. But this gives a flavor of kind of the way we were thinking about things in these commissions. And in this particular case, some of the major problems that emerge from the numbers, but don't necessarily emerge at first glance from the numbers. You have to play with them a bit. So that's just an illustrative slide. The next picture shows more pages than you ever want to consider on the, as publication from the third round of work on disease control priorities, publications around 1917, 1918. So volume 1 is on surgery, maternal and child health, cancer. So it reflects a lot of the concerns of dealing with major non-communicable diseases and hospital addressed conditions. So there's been continued controversy about it. I'm told, but I don't have any independent judgment of this, that there's only one person in the world who's read the whole thing, and I confess it certainly wasn't me, but apparently Bill Gates, who reads very, very fast, read the whole thing. So, and everybody else who's read it at all has, I'm sure, dipped in and out, or maybe spent a fair amount of time with one volume or another. The work is continuing. That's moved on disease control priorities from North America to Norway. Norwegian foundations, Norwegian government have been investing heavily for many years in the ethics and economics of priority setting in health. There's a center at the University of Bergen on exactly that, ethics and priority setting in health. And that center, under the direction of Ole Norheim, is taking on responsibility for a much smaller disease control priorities effort over the next 2 or 3 years. But again, as with the first 3 editions, these were all, the first one was very much completely a creation of the World Bank. The next 2 were published by and in collaboration with the World Bank. And the World Bank will be closely associated with this 4th round. The current director of health at the World Bank is former, I think, health minister in Nigeria, Mohammed Pate, but extraordinarily intellectually engaged as a manager, and he's been a pleasure to work with on these questions. So a lot of this work continues, and those of you that have interest either in reflecting on it or getting engaged with it, happy to stay in touch.
So thank you for this very comprehensive presentation, and they have raised many questions already. So I think we can start with some of them which have to do with the background, the general aims of the WDR report, and especially the previous debate associated with the question of health and financing. And we have here 2 questions by Valerie and Christopher on users fees. Valerie asks you, I guess you can see the question in in the chat there, so I won't read all of them, but recap. Valerie asking about the World Bank staff and many at WHO continuing to believe that users' fees are a usual instrument, and Abdo started to respond about that, but Christopher sees has enlarged the question on the ways in which the bank had monolithic commitments to these, and asking about the differences between economists based at headquarters in country health economists or mission staffs, and saying that it seems that the bank had cooled somewhat on users' fees a little since the papers by De Ferranti in 1985 and 1987. I mean, which were very much about financing, so far as I remember, about financing mechanisms. And I would suggest that besides the specifics about users' fees and the debate of the time regarding their status and the impact, you enlarge the question to that George raised, which is how aware were you of going well beyond the Washington consensus and beyond earlier World Bank positions? And I would link that to my own specific question in this respect, which has to do with the changes within the population, health, and nutrition division or department regarding these debates about financing. I mean, it's telling us a little bit more maybe about the ways in which the work associated with the writing of the report displaced discussion within the PHN division. So, Abdo?
So I can start with my knowledge of the World Bank since '96. Moving forward, Dean may want to talk about a slightly different angle. On user fees, Dean will correct me, but WDR 93 was not very positive on user fees. And so it sort of was the antidote to the 1987 paper, which had put user fees as one of 4 policy priorities. WDR, I remember even interviews Dean was giving during the launch of WDR, specifically saying, here were the 3 objectives of user fees. And in 1993, we're quite sure we're not achieving any of them. And so it's not necessarily an important thing. Moving forward, I was 10 years as a manager at the World Bank. In those 10 years as a manager in 2 large regions, Europe, Central Asia, Sub-Saharan Africa, not once did any of my staff, whether they're field-based or Washington, pushed for, identified, or even mentioned user fees as a priority. And that's part just, I pull whatever hair I have left, because since the 1987 push by the bank on user fees, the whole academic world, certainly the left side of the academic world, which I like to belong to, I'm very much a left-leaning economist, still says the World Bank is pushing for user fees. Even the comment here says WHO is pushing for user fees. Neither institution has been pushing for user fees for a long, long time. And so I don't know what else to say. It just, it's not something that's real, but it seems to live in academia, and I don't know what to do about it. I'll leave to Dean the question about the Washington consensus. This was way above my pay grade.
Well, certainly I think Abdo is quite correct that as we thought about user fees, and we did think a lot about user fees in our work on WDR 93, the conclusion was just not to directly contradict the major 1987 paper Abdo referred to advocating user fees, but to treat the subject with silence. And to some extent replace the question of rationing of services with money to how do you focus a benefits package or public resources on the poor. And that, one way of doing that is rebating user fees. extremely administratively difficult, close, in my view, to infeasible, concentrating on geographical areas that have a lot of poverty. I think in the end, we, without disagreeing with that completely, concluded that focusing on the diseases that were most affecting the poor. I mean, tuberculosis would be a classic example. It's a disease that heavily addresses the poor, and so that would be, in our analysis, would have been a strong reason for prioritizing public finance of tuberculosis, partially because it was efficient, lots of deaths averted per $1 million spent, but most of those deaths would be averted in the lower income part of the population. So that was really the alternative to user fees. On the bank's attitude toward the Washington Consensus, the role of user fees and that, I was outside the bank at that time in academia, pretty much moved, but I perceived two extremely different perspectives. One was that the people in the World Bank that actually did the work, that, like Abdo, developed and managed projects, worked closely with countries, that I hadn't realized, Abdo, that it was quite so absent, but I certainly would have pictured the user fee story, the private voluntary insurance story, as not on the agenda of World Bank operations. But there are a lot of economists in the World Bank, and they are a more visible face of the World Bank. And I don't think user fees went away that quickly among economists that were still writing about health. So I view that as a divergence. I think there's a question about inconsistencies on health finance across different regions of the bank. I think much more so than on macroeconomic policy, where the bank sang, I would say, close to a single tune for a long time. There was much more diversity on healthcare finance, but ultimately not going back to heavy reliance on out-of-pocket finance.
Okay, thank you. Thank you. Well, there is another question related to the general perspectives or the aims associated with the report and its relation to general economics, which was asked by Ruth, saying, you mentioned that universalism, universal healthcare and coverage was or is viewed by some at the World Bank as coercive in terms of the state determining what was universal. And and she is asking, I did not really understand your statement, this position, and wonder if you could elaborate on that. And I would link that to another point you mentioned briefly in your first presentation, Dean, which is about the fact that the WGR report was a strong plea, I would say, in favor of public investment. At least in
favor of what? Excuse me.
In favor of public investment in health.
Yes.
Yeah. And so, if you can link this question of universalism and public investment and the ways in which this was somehow problematic or resisted within the bank at the time when you were writing the report, and because it seems that there were significant debates around these issues with some levels of the bank.
Well, let me take a pass at least part of that. If you wish, the economization of health at the World Bank, and what I think of as one of several misperceptions about WDR 93. Much of WDR 93 was basically about what to invest in, how to invest, but there certainly was an argument about why, and the conclusion of that argument was that it was really quite important to start spending a lot more public money on health and investing in health. But we quite explicitly were not talking about an investment that would yield returns that were easily measured in money. For example, if the bank is investing in an hydroelectric project associated with a new dam, the valuation of the benefits of that project will be first kilowatt hours of power, or megawatts, at different times of the day, perhaps. And those megawatts would be assigned each a dollar value. And so there would be dollar valued or monetarily valued benefits. And a lot of education projects at the bank were justified in that way. We discussed and quite early on decided that that was not going to be the way we dealt with benefits, and therefore the way we dealt with advocacy on health. And there are a variety of reasons for that, but Summers had, among other things, gotten himself in a lot of trouble politically, almost got fired actually, for talking about monetary value of mortality reduction in an indirect way. So what was the rationale for this investment? Basically, it was that the technology for improving health, the vaccines and the drugs against the big sources of mortality, were extremely powerful and extremely cheap. And people really cared about their health and their children's health. So health conditions, because of that technological place the world was in the late 20th century, in the mid to late 20th century, you could buy far more gain in human welfare by intelligently allocated expenditures on health than you could buy from increasing per capita income. So that in that sense, the welfare gains were not being sufficiently prioritized relative to the welfare gains from investing in economic development more traditionally defined.
If I may, on the universal argument, universality, I think what Dean was referring to in his comments was a strong libertarian sense within the bank's macroeconomics and in high-end sort of thinkers about coercing people into something. So there was a pushback early on, at least from what I could see from my very low level, being the guy who carries the bag for the team, that there was this push about why are you pushing this on everybody? But there's an actually very interesting set of debates that followed, in which I actually was aligned with the economist against the public health people. And it goes around the concept of universal health coverage, in the sense that the public health people continuously say two things that have been empirically proven to be incorrect. And unfortunately, Dean has even said them once or twice. One, there's this sort of crazy concept that investing in health is the same as investing in poor people. Absolutely not true. And there's the second statement, which is slightly less bad, but bad anyway, was that programs for the poor are poor programs. In fact, it was the economists in the bank, even people that Dean and I struggled with, like Jeff Hammer and others, that actually had done fantastic work in East Asia on something called benefit incidence analysis. And that is to identify where the gaps are in this universal coverage. And in fact, arguing that if you keep pushing just universality without understanding where the holes are in the system, that you're actually producing more benefits to the wealthiest segments of society away from the poorest segments of society. So many of us since then have worked on the other side of it, is to say what we mean by universal health coverage is plugging the holes that relate to the poor. That's why we were very excited when the WHO came out with their definition of universal health coverage, which two of the three dimensions related to inequality. So that's an interesting, lively debate about what do we mean by universal and how do we go about getting to universal. And it included in it something related to user fees. Some of us have been pushing something which is a negative user fee, which is conditional cash transfers, which started in Mexico, Progresa Oportunidades, which actually paid people to seek care. So it's a negative user fee. And it was seen as a way to actually use financing and incentives to get poor people access to services, education as well as health services. So this universal argument is quite interesting, but in a very different way than it was when Dean was starting the WDR. It has changed in both directions. That's where I find myself leaning right and not left when it comes to public health people who keep insisting that the poor can take care of themselves if we fund healthcare. Not true.
Thank you. I suggest we switch to a couple of questions which have to do with the packages. So in a sense, the way the fabric of this perspective about essential packages and the way of prioritizing that was a part of the report. So the first question is general one, which by Nancy Thomas, who is asking, in the social sciences literature, there has been a lot of criticism of the package approach and the use of uniform protocols for diverse cultures. So how would you counter that criticism? And on issues of the ways in which the cost effectiveness evaluation and the packages were assessed or designed. Manjar is asking, in your work on cost effectiveness and on packages, was your work informed in any way by histories of health outcomes in European countries? So, I think we can link that to a very important question that Claudia Long is asking to Dean more specifically. Why has it taken until very recently that the bank has become interested in depression, although GBD and DALYs have brought out it to the fore already in the 1990s? And so far as I remember, in the DCP, there was the first DCP, there was a section on mental health, and the supply of drugs against depression was included in the first essential packages. So this is also raising an, I would say, a very important question, which is about the various diseases taken into account in the packages, and the fact that non-communicable diseases was viewed as an important innovation and an important legacy of the WDR report. So if you can comment, the two of us, about these different dimensions of packaging design, sources of information, and what's included, what's not included.
Maybe I'll let you comment, Abdo, on package design, and I could comment on the specific question of psychiatric disorders and intervention against those in the packages, and a little bit of where I see that discussion going now. And yes, it's quite correct that we had a chapter in DCP1 on schizophrenia and manic depressive illness, I believe, and some of the off-patent drugs are not that expensive and probably work fairly well, though I'm inclined to think these days they maybe don't work as well as before. Some of these questions are kind of, why things get where they are, maybe have stories that are not completely intellectual. And on this particular point, my sister is a professor of psychiatry at Johns Hopkins University, and had I failed to pay proper attention to psychiatric disorders in my work, I would have had a little trouble from my sister. But the other, as noted in the disease burden work, a huge burden and partially effective medical interventions and perhaps non-medical interventions. Where I think that discussion, part of that discussion stands today that hasn't certainly wasn't something we paid attention to and should have in the World Development Report or in the first disease control priorities, is that of long-term care. And a lot of long-term care has to deal with declining cognition, Alzheimer's, and related dementias, mostly in the elderly. Long-term care for non-psychiatric, non-dementia reasons in the elderly. But dealing with psychiatric disorders, persistent, strong psychiatric disorders, requires, I think, long-term care that is humane, and perhaps doesn't have a high expectation in some cases of cure or major regression, but still care and humane and just care are essential. So I see in DCP4, I hope we will pay much more attention to humane long-term care and its costs, not as an alternative to using the drugs where they will work. Certainly, that's if the price is okay, that makes a lot of sense. But humane long-term care is really, really important, I think.
So there were two questions. One related, do we pay attention to European history? And the second part was on packages. As definitely we did not pay attention, all my professional work at the bank, along with a lot of colleagues, we rarely paid attention to American history because that was the disaster module. We didn't want any country in the world to replicate the American model. We preferred the Canadian. In Europe, this is tricky. And so, for example, let me give you a negative example of not learning from Europe. So the European, largest European engagement on health financing relates to labor tax financing through social health insurance. This is Otto von Bismarck in Germany in 1880s, taking 600 years of history in Europe of guild-based insurance and then turning it into public policy. This is how social health insurance came to be. What I find frustrating is when European development agencies then go to Egypt and say, oh, let's learn from Europe and let's start a labor tax social health insurance in Egypt. Egypt, who does not have 600 or even 6 years history of any kind of health insurance, to take a European 600 years of history and to try to apply it to Egypt or Haiti or Togo or Ethiopia is crazy. So as a general rule, I don't look for high-income countries to show me the way for low-income countries. And none of my colleagues do. Unfortunately, development agencies in Europe and in the US do. So we're constantly fighting the German agencies pushing social health insurance, the US agencies pushing private health insurance, the worst possible way other than user fees. And so there's that history, bad history, that we're trying to fight. On the benefits package, or on the package, so in the slide I showed you on Bangladesh, which I think should give you a sense of what we tried to do, I think the question was hinting at, are we cutting and pasting from WDR 93 to 28 countries around the world that were implementing benefits package? In general, not at all. In fact, I documented it in my paper, which I put out in 1992 as part of training. I was running training for the World Bank on how to do this. And I showed in it how much time and energy the Bangladeshi population took, or the experts, the thinkers in Bangladesh, took to define their own benefits package. And it included identifying 18 top technical experts who are all Bangladeshi, who went through voting exercises to try to determine what's in and what's out. They used the WDR 93 as a sort of a potential way to think about it. They used the data, but they realized that was a global effort that was put together by a few people in a time-sensitive way, that they needed to customize it. And again, in all my engagements, and I've worked on 57 developing countries, nowhere did we ever cut and paste. Nowhere did we ever cut and paste. And so again, I find it strange that there's this perception that this was just taken. Now, in some countries, they took more from WDR3 than others, and that's their choices. But as a general rule, those of us who worked in operations did not take the text of WDR as the Bible or the Quran, and we did not just cut and paste. We used it as a way to think, as a way to document, as a way to help countries think through how they can do it. Thanks.
Thank you. A follow-up question on related to what you said, Dean, about long-term care, which is this question by Emily Harrison about timelines in the World Bank imagination. Has the bank took on health projects, disease and debility reduction? How fast were projects expected to get underway to show results? How did time figure into operationalization? And this is also related to what I was alluding to about the non-communicable disease and the shifting perspective associated with chronic disorders, and the ways this has also hinged on the difficulty to define effectiveness.
Well, a couple of reflections on time schedule and when outcomes can be measured. One observation I made about the bank is that people who work in operations, mostly like Abdo, correct me if I'm wrong here, must have a pretty long time perspective. Takes several years to come to the development with national authorities, national academics, and others. A legally sound, technically sound project takes 5 or 6 years to complete it, takes 2 or 3 years to look back, draw the lessons, maybe carry on with some parts. So I view that as at least a 10-year time frame, whereas in the research community, the economist community in the bank often wants answers out of 2 or 3 years. They want to do a research study that shows that such and such a program of, let's say, conditional cash transfers, to use Abdo's example, had an effect in 2 or 3 years. Why 2 or 3 years? Because that's kind of the cycle on which academics get judged and promoted, particularly younger academics, as most of the World Bank economists were. They've got to get their publications out, and that means getting this stuff done quickly. And so there's that disjunction. And there's a disjunction further between the 10-year time horizon of a World Bank operation and when you might expect it to show effects on health outcomes. Maybe you could see quicker effects on financial protection. I think you could, but to change major health outcomes, sometimes you could see that in 10 years or less, particularly some infectious disease projects. But if you're looking at a tobacco control project and prevention of initiation of smoking, the effect of that on mortality is 60 years away. And the effect of hepatitis B immunization on mortality from liver cancer is 40, 50 years away. So those time horizons need to be built in to project design and in the conversations. It isn't particularly easy. And but all I would note, I guess, basically is what I perceive to be as a relatively short-term view of the academic economic research in the bank and the longer-term view of World Bank operational staff.
Thank you. Thank you. This brings in one the complementary question about the assumption which were brought into the WDR and especially related to the global burden of disease and the way the two came together. So far as I remember, in the fabric of the report, the global burden of disease result came pretty late. That's why it came in late. I mean, you got them at in the final stage of the writing of the report, if I'm not mistaken. And Emmanuel Björn is asking, can you share with us further insider knowledge around which assumption incorporated into the report, GBD-based analyses, were most contentious? DALYs and the differential valuation of life, or CEA that rests on time delimited benefits. So what kind of debates were taking place at the time of the preparation of the report around the GBD, its value, and the assumption associated with it?
Well, the generation of the burden of disease numbers began, the attempt to do that right at the beginning of the WDR exercise. It took a long time, and I think it's correct, whoever noted that we didn't have the results until fairly late in the day to use. We were able to use them. About 2/3 or 3/4 of the way through the project, Summers asked me how far along was the burden of disease work that he observed, spent a lot of money on, and what was the probability that we would have it in time to use. I said the probability was 0.8, 0.9. Summers looked at me and said, not good enough. And he had ways of giving you incentives to make things better. So we did lean on that team. In retrospect, I think there are lots of things that I don't find useful about it, even though, as I showed, I was a co-author of that first paper on burden of disease measured in disability-adjusted life years. The continually shifting way of constructing the DALY and the YLD, the disability component of the DALY, that just changes in non-transparent ways all the time. And economists now use a very different DALY for cost effectiveness work than the disease burden people use for disease burden work. So I, in retrospect, think it was a step backward to move away from age-specific mortality rates and a few specific areas, and there are only a few, where there are big chunks of disability, and just to keep track of those separately. But that's not at all what most of my colleagues feel. They think trying to do the DALY a little bit better is the way to go. I would like to see it dropped, frankly.
Thank you. So Martin Gorski is coming back to the macro level debates at the bank and the relationship between health and development, saying, would it be fair to say there is an ongoing macro level debate at the bank on the relationship between health and development, meaning healthy human capital is a necessary precursor to growth versus health service have to follow growth? And it suggests that the WDR was arguing strongly for the first position, though Abdo's comment around the Preston curve slide suggests that debate was still running. So about this, health as a which is about something which has been very much discussed outside the bank as well, in terms of health as a factor for growth or health as a consequence.
Right. If I may just give you a sense, I'm a trained econometrician applied to health and labor. So I worry a lot about what you can and what you cannot say with data. Causality is a very challenging thing. So what we know for a fact is that health and economic development are correlated. Preston curve and everything else has produced since. Yes, the debate continues, and it'll continue as far as I'm alive, because you can never prove one versus the other. You just cannot. There's not enough national level or even subnational level data to do a clean econometric analysis that shows you which one came first. But I can tell you the argument I have been using for the last 7 years. I looked at all the data available for East Asia. So East Asia is a fantastic region to work because it's famous for what's known as the East Asian tigers. These are a few countries that somehow were able to both improve health outcomes and grow economically. And it did something ridiculously simple. I mapped or I graphed economic growth and infant mortality rates and child mortality rates for all these tigers. And something fantastic jumps out. And that's the argument I've been using within the bank and outside the bank. In every one of these countries, China, South Korea, Singapore, Thailand, Malaysia, in every single one of them, the infant and child mortality rates improvement came before economic growth. So I have a very non-econometric but visual way to argue that if it's economic growth that drives it, then somehow these East Asians were so smart. They realized economic growth is going to happen in 10 years, and then they got the health outcomes first. So in my book, and in these regions, it's very clear. Investments in health came before, and those investments in health in many ways led to the production of economic growth. In fact, there's a whole research on population, looks at the impact of declines in fertility rates on economic growth in these countries, and shows something called the demographic dividend, which actually shows that decrease in child mortality, decrease in fertility were precursors to economic growth, and in some calculations accounted to a third to a half of economic growth in these countries. So there is a lively debate. It'll always be a lively debate because there's not enough granular data for an econometrician or econometricians to tell you this happened. But for those of us who work in health and population, the evidence is fairly strong that investments in health in countries that have achieved both came first.
Dean, if you want to say something about the dynamics of the debate at the bank?
I'm more aware within the bank of the argument about the extent to which income growth or income level affects mortality rather than the other way around, on the effect of mortality or health on income growth. I absolutely agree with the power of the examples where the economic growth has followed the improvements in health. I mean, China is perhaps the most striking example of that, but the other East Asian countries and other countries as well. On the causal relationships in the other way, I've worked on that from time to time. My conclusion, but it's, I think, not quite the standard conclusion yet, is that when you do the econometrics as well as you can, given the major limitations of these cross-country time series data, if you do the econometrics as well as you can, you find that the effect of income growth on the rate of decline of under 5 mortality is much less than a literature of 10 or 15 years ago, including some literature generated for the WDR, that you don't see much effect of income growth or income level on mortality, or at least child mortality. That's not true of education. When you do the econometrics right as I would define it, I'm not an econometrician, you don't see a reduction in the effects of education, don't see much of a reduction. So education kind of stands up as a determinant of health. Income does not. And again, the interpretation I put on it is that it's really a question of some countries have bought the cheap technologies and invested heavily in the right things. Didn't cost them much. They could do it when it was poor, when they were poor. Other countries didn't. And so you get a huge variation in the rate of decline of underlying mortality, but it's not an income level caused variation.
Thank you.
I don't think that's settled among economists.
And we have one more question about the legacies of the report. Manjari asking about, could you reflect more on the importance of the report and ensuring similar work for Bill Gates and the Gates Foundation? So coming back to the various places where the report was taken in or not.
There was a major article in the New Yorker or someplace about William Fagey, who was a famous head of CDC, I think, and public health physician, who was an early advisor to Bill Gates. So the story I read, and I don't know this personally at all, was that Bill Gates had asked Bill Fagey for some suggestions on what to read about health. And one of the suggestions was WDR 93, which he read and felt convincing. He then had some correspondence with Larry Summers. Summers shared part of that with me a little bit later, saying how much the report had influenced his thinking about where the foundation could do the most good with the amounts of money it had. So I think it's at least plausible that the report, by pointing to the large amount of really low-hanging fruit that was out there, influenced the early days in the foundation. Gates has continued to be involved with the disease control priorities, for example. I've been in meetings with him where it's just extraordinary the kind of specific details he would pick up out of 200 pages of background, thickly condensed background material. So he's picking it up. He's not just skimming it.
Well, can I push you a little bit further on this? Because would you, well, to some extent, one may say that what has been taken in by the Gates Foundation, or at least advocated, is the DALYs and the GBD kind of assessment and evaluation, but the ways the report and the disease control priorities try to advocate and provide tools for central planning, and therefore for having an overarching health system oriented approach involving all sorts of disease and a comprehensive picture, has not been much at the center of what the Gates Foundation is doing, or am I mistaken that what the foundation has been doing is much more in tune with the disease-oriented kind of programs that dominate in global health?
Let me comment on that. I can take more time, but I might get interrupted by a call that I'll have to tell her that I'll call her back shortly. So apologies in advance, but I'm happy to take some more time. The Gates Foundation has supported the Institute for Health Metrics and Evaluation at the University of Washington under Chris Murray's leadership, and supported it extremely generously in terms of the kind of money that goes into demographic and epidemiological research. They have ended up essentially with no competition. The quality of their work, and this is a judgment of mine, but others differ, a lot of the quality of their work is poor. The broad objective of the work, I think, is reasonable. but you don't need to try to redo it every year, every 5 years. And further, the replicability of their work by others is, you just say bluntly, they don't let it happen because you can't get their data. In many cases, some cases you certainly can. But for example, I worked quite a bit with a person at WHO who deals with Horton disease. And I remember him being asked whether he agreed with the estimates of maternal mortality that were then coming out of the IHME. And he said, well, he didn't know whether he agreed or not. He, the World Health Organization, had explicitly asked the IHME for the data on which they could form an independent judgment about those numbers, and he wasn't able to get it. WHO wasn't able to get it. So they have a monopoly position and are not easily challenged because of both the monopoly and also the maintenance of closed data sets. And that's why the journals let that happen. I mean, I thought it was a prerequisite for publication in scientific journals that
I hope you've asked Horton at Lancet, Dean, why that is.
I've asked him. To tell you the truth, he gets a lot of heat for the publication of. I just got in the mail the Lancet with that thick of, the exact number of deaths from myocardial infarction in 1998 in Rwanda. I mean, it's just a fairy tale. Why Horton publishes that, I don't know. I think it's actually benefited me because Horton's got so much criticism for that. And let me say, it's pretty well understood in this business that Chris Murray and I don't get along. So Horton, I think, has bent over a little bit backwards on publishing the disease control priorities work to attenuate. I don't know if that's true, but he's certainly been very supportive of the disease control priorities, and in most ways I find it reasonable. I simply don't understand why the journals let them get away without making the data available. I just don't get it.
So thank you so much for this very rich conversation. George, do you want to say something?
I just wanted to ask Dean, it's a really personal question, but in terms of my own research, but how did you end up becoming the lead author of the ad hoc report on health research?
I'm not sure I know the answer to that, but it certainly would have involved my having strong intellectual relations with Jim Tulloch and Turi Goodall. Tulloch was at the time head of maternal and child director for maternal and child health at WHO, and Turi Goodall was director of the tropical disease research program at WHO, and I had served from time to time on their advisory committee. They were both unhappy with the kind of discussion of R&D priorities coming out of the relevant part of WHO. They were very unhappy about the situation that I described earlier, where 3 or 4 of the foundations providing major support for mostly tropical disease research, but other were simultaneously deciding that their catalytic role was over. So Tulloch and Goodall were very concerned about that. And I think we must have had some conversations over dinner. I don't quite know what happened, but they ended up finding some money to establish a commission. We had 3 R&D pharmaceutical company vice presidents and people that kind of knew a fair amount about the development process. Goodall knew a great deal about it. I think Goodall was concerned that there was not sufficient attention to the power of private sector capacity and the ability, if you played the private sector right, to get a lot of freebies from them. And he certainly spent a lot of time at that, and he was well acquainted with the senior R&D people at quite a few of the big drug companies. So that's a non-answer, but it kind of describes the context anyway.
Okay, thank you.
Thank you.
They were actually both co-authors of that report, if I remember correctly, and they both represented special programs at the WHO, which meant that they were used to having extra budgetary funding that was not WHO funding. So they represented a very particular element within the WHO.
Well, I think that, I don't know the numbers for sure. I think that's probably much more correct for Goodall and the Tropical Disease Research Program, and that the Child Health Program was probably better integrated.
Mm.
Both of them were longtime WHO officials. But to get back to a bit of the question about gates and relatively vertical programs or disease-specific investments in new products and implementation, things like Gavi, or definitely there's a strong flavor of concern with specific diseases in the disease control priorities work in the WDR 93. It's a way of thinking that I'm very sympathetic to, that Larry Summers is very sympathetic to, that many of our colleagues are not sympathetic to. But to return to Goodall and Jim Tulloch, very definitely, they're kind of very technocratic people, and that was certainly the flavor of what they were trying to get, as I read it, what they were trying to get out of that report, that working group.
Okay, well, our time has passed. I want to thank Dean and Abdo for being extremely generous with their time and with their memories, and for being so thoughtful and somewhat self-critical about their careers. It's a very refreshing thing to hear people like you talking about your work in the past. And I would note in passing, I think that WDR 93, I agree totally with Abdo, has been misinterpreted countless times by countless people. And I think, getting a better understanding of what was actually said in the report, as opposed to what was attributed to it, is, I think, a very, very useful and a very, very helpful thing. So I really would like to thank you very, very much for your cooperation. And I hope we can continue this